and but it is uploaded. In this lecture, traditionally, you give 2 lectures on 6, 7, and 8. 6 is about the osteology of the bone. In other words, about bone formation, how bone forms, how you classify bones, bone breaks, and bone pathology. And 8 is about joints, and 7 is about the individual bones and the anatomy, and that's traditionally done in 1 or 2 labs. Usually, if you have the 15-week course, be done in 2 labs. It'd be an axial skeleton lab and an appendicular skeleton lab, and then you'd have a quiz afterwards. At the end of this, it's probably going to last a little over an hour, and we're going to look at the lab thing, look to see what I've got together. And after you see what you're going to do, it should be as simple as the other lab. Everybody should make 50 points on it, because you're going to make your own word list about the individual bones and structures. You just have to watch 2 videos, one of which is about 6 or 8 minutes, and the other is about 4 or 6 minutes, and make you a word list. And we'll talk about that when we get done. So now we're going to talk about the skeleton, and we'll go into that in a little bit more detail. Going to talk about the skeletal system. The functions of the skeletal system, as you can imagine, number 1, support, okay? If we didn't have a skeletal system, we would be flat on the ground, okay? We'd be flat on the ground. We wouldn't be able to get ourselves either up on all 4 or upright on 2, okay? Protection, obviously, it's very important for organs like the brain, the spinal cord, the heart, and the lungs. Give some protection to the kidneys and some protection to the pelvic structures. It's very important movement because we have to have a lever system for the muscles to attach to. All the muscle does is contract, okay, in one direction. That's all a muscle does is contraction in one direction. It has no idea if it's flexing, extending, abducting, adducting. You'll learn all those terms when we get to muscles. It has no idea if it's doing all that stuff. All it does is contract, okay? Well, depending on what our origins and our insertions are of the muscles, that allows us to do the various movements. And then for mineral storage, it's a big storage site for calcium and phosphate. It stores other things, but that's the big thing it does is calcium phosphate. Some of the long bones and some of the other bones serve as reservoirs for hematopoietic production of red and white blood cells, okay? It also, in the long bones, if you don't have red blood cell production, you may have some fat storage, and then obviously there's some hormones that cause regulation. Oscalcin is one, but we pick up more hormones when we talk about the endocrine system, so we're not going to worry so much about the hormone in this particular thing, but there are a number of functions of the skeletal system. This is the major classification. There's an axial skeleton, which is a cranium, a vertebral column, and the ribs. That's all it is, cranium, vertebral column, and the ribs, and that would have been our first lab. We had a traditional class, and everything else is the appendicular skeleton. Shapes of bones. You have to remember that all this stuff was just made up, okay? If you think about it, there was no names from anywhere. Everything was thought of and classified and brought together in groups. And so this is a classification, just a general classification. It's not anything that's a very rigorous thing. I'm not going to ask you if it's a long bone, an irregular bone, a flat bone, or a short bone, okay? But it is a classification for trying to work in what type of bones going to have what general shape. A long bone usually has a shaft and 2 ends. It doesn't have to be too long, okay? But it is longer than it is wide. A long bone has a shaft and 2 ends. It's named for the shape, it's not named for the size. Short bones are the cube-shaped bones. They're usually the ankle and the wrist bones, okay? And then there's sometimes inside of tendons, there's little bitty tiny bones called sesamoid bones. They're not named bones, and it's not something you'd have to learn. Flat bones are things like the sternum, the cranium, the ribs, okay? Those are flat bones. And then finally, if there's no other places you can put them, it's not a long bone, it's not a short bone, it's not a flat bone, then it's an irregular shaped bone. And usually the quintessential example of that is the vertebra. What are compact bones? When we did chapter 4 and talked about tissue and talked about bone as a connective tissue, we looked at the Haversian systems or the osteons, okay? This is what a Haversian system or an osteon looks like. This is the general structure here. This is one osteon here. This round thing here is one osteon. In the old days, it was called a Haversian system. That I'm sure Haversian is somebody's name. The canal that carries the artery, the vein, and the nerve is now called the central canal, but used to be called the Haversian canal. Around this central canal, around the Haversian canal, in this osteon are lamella. I think of these like tree rings, okay? These are lamella that are very strong and provide the strength to the compact bone, okay? They are called lamella. We have these vessels that are going through this central cavity here. We have these vessels that are going to the central cavity, and we have connections with these vessels, which go through Volkmann's canal or the perforating canal, okay? We have connections going through these vessels, which go through Volkmann's canal or the penetrating canal. We have endosteum. Remember, we have linings on everything. We have endosteum that lines the inside of the bone. It lines each one of these canals here. It lines each one of these vessel systems here, and that is called endosteum, okay? The tissue that lines the outside of the bone is called periosteum. They are vessels that go through the periosteum. There is a vessel on the outside of the bone that sends fibers through the periosteum for nutrition, okay? Those are called, the perforating areas are called Sharpey's fibers. If we look at one osteon, a portion of one osteon, this is the central canal, the Haversian canal. There's a nerve. There's the nerve, traditionally in yellow, artery in red, vein in blue. They are, I don't know why this keeps doing this on me. They are these concentric lamellae that go in opposite. So this would be laid down in this direction. This would be laid down in the opposite direction. But these are concentric lamellae, okay? In the concentric lamellae, they are lacunae. They are lacunae. These are little chambers here. And we'll learn that what happens is the osteoblasts are going to be the cells that lay down the osteoid, which is going to become hard, okay? As they become walled off, okay, they're going to lay down osteoid in all directions. Eventually, they're going to become walled off. When they become walled off, they're going to be walled off in these little chambers called lacunae, okay? When they become walled off, they become osteocytes, and their function is to maintain the bone matrix in their localized area. So they are osteocytes that are walled in to these lacunae that maintain the bone in their general area. And then we have these smaller little called canaliculi here. These are smaller little tunnels that bring nutrition into the osteocytes, because remember, the osteocytes are now walled off. And so we have a number of structures here. And so the osteon is not a hard structure to learn, but it's a fascinating structure to learn. It reminds me of tree rings. Compact bone is the bone, okay, that is hard and dense. When we're looking here, this is compact bone. When we're looking here, this is compact bone. This is spongy bone. There's two types of bone. There are compact bone and there are spongy bone. This is compact bone. Compact bone has the Haversian systems, has the osteons. Spongy bone does not. Spongy bone contains no osteons, but rather an irregular lattice work of bony matrix. And this here is the skull. This is a slice of the skull. This is and so the skull here, skull is a flat bone. It has a label. It has a layer of compact bone, a layer of sponge bone, and a layer of compact bone. And if you learn about the, if you're in a particular thing where you learn about the uh, basic anatomy of the skull, this is called the outer table. This is called an inner table. Okay. And you can have actually a fracture of the outer table down into the spongy bone and not fracture the inner table. You can still probably have a contusion, because if you have enough force to break the outer table, you're probably going to contuse the brain, which is just right underneath here. Okay. But this is the outer table, which is made of compact bone. This is the inner table, which is made of compact bone. And in between it, we have this spongy bone. And we saw through those Volkmann's canals that blood vessels are going into this area. This is all spicules of bone. It is covered by endosteum. It is served by blood vessels, and it serves a specific function. Anatomy of a typical long bone. This is something you're going to need to know. The shaft of the long bone is called the diaphysis. The shaft of the long bone is called the diaphysis. It's made up of compact bone on each side with a hollowed out central portion. So it's made up of compact bone on each side with a centralized portion that's hollowed out. So this is the diaphysis. This is the shaft of the long bone, okay? The epiphysis is the end of the long bone, okay? We have two epiphyses. We have the proximal epiphysis, and the distal epiphysis. We have the proximal epiphysis and the distal epiphysis. So this is the humerus, and so this would be the portion that is closest to the shoulder, and this is the portion that's furthest away from the shoulder. This would be articulating with the radius and ulna. So in addition to having a diaphysis, a single diaphysis, which has compact bone on the outside and a hollowed out shaft in the middle, we have two epiphyses. We have an epiphysis, a proximal epiphysis, and a distal epiphysis. The epiphysis is made up of compact bone with spongy bone inside. The epiphysis is made up of compact bone with spongy bone inside. Just notice this. This is our diaphysis here. There's two things that can happen in the long bones. One, they can be a site of hematopoiesis, where we're making red blood cells and other cells, or they can store fat. And so there's this fat inside of a long bone. Why is that significant? Because one of the things that you could get if you have a femur fracture and there's fat there, if you have a femur fracture and the bone is completely fractured in two, obviously there are blood vessels broken in the area. You can actually have some fat emboli, so you can have the patient complaining of shortness of breath and being hemodynamically stable, having a good hemoglobin, hematocrit, blood pressure being fine, but being short of breath, and it could be because the patient has a fat embolus. So you just always keep that in the back of your mind if you're going to take care of trauma patients or take care of patients that have femur fractures. We have this medullary marrow cavity within the diaphysis. It's either an area of blood cell production, red marrow, or an area of fat storage, yellow marrow. We have membranes, okay? We have an endosteum, which covers the internal bone surfaces, lines canals, and covers the trabecula. The trabecula are those pieces of spongy bone that go in all different directions, okay? The trabecula are those pieces of spongy bone that go in all different directions. One of the things the spongy bone does is cut down on the weight, because if you think about the cranium, you've got an outer layer of compact bone, you've got an inner layer of compact bone, and then the major thickness of the cranium is actually the spongy bone. Well, obviously the spongy bone does not weigh nearly as much as the compact bone does, so it cuts down on the weight of the cranium. So it provides protection while cutting down the weight of the cranium. We have a periosteum. So the endosteum is the inside layer. The endosteum is the inside layer. The periosteum covers the diaphysis of the bone, except for the joint surfaces. The periosteum covers the diaphysis of the bone, except for the joint surfaces, and it consists of dense, regular connective tissue, because it is all going in one direction. It is going up and down the bone. We have articular cartilages, okay, on both the proximal and distal side that cover the outside of the epiphysis, and they cushion the bones during the movement. So we have a diathesis, we have a proximal epiphysis, and a distal epiphysis. We have articular cartilage on the proximal epiphysis and on the distal epiphysis, which cushion movements of the bone. What happens is a lot of times you will wear, especially in the knees, you will wear the articular cartilage out over time, and you'll go in and the doctor will say, listen, you really got bone on bone. You're saying, you're not telling me, because I can almost hear it grinding. But you can wear the articular cartilage out. And so those are, and remember that the diathesis of the long bones has a central canal here. This is not spongy bone in here. This is an open central canal that can either have red marrow in, which is going to be responsible for production of red blood cells, or it can have fat in there. The epiphyseal line, okay, let me show you the epiphyseal line here. This epiphyseal line here is a remnant of the growth plate. It's a remnant of the growth plate. When we hit our growth spurt during puberty, this is where it occurs. It occurs in the epiphyseal line. When we hit our growth spurt in puberty, it occurs in this region here, okay? It's actually called an epiphyseal plate until it fuses, and then it gets very indistinct, and it's called a epiphyseal line. Why is this important? If you have a teenager or a young person come in to see you and they have a fracture through the epiphyseal plate, then that is an automatic consultation to an orthopedic surgeon, okay? If their epiphyseal plate is still active, it has not fused, it is not now an epiphyseal line, then just like with the fingernail, where you have a germinal matrix, this is where the bone is growing. So these areas need to be put back together exactly and fixated in whatever manner they are, okay? So that you hope that you can get some growth there, because if you don't get growth there, then if this is in the femur, okay, if this is in the femur, then you're going to get leg length discrepancies. And depending on how big the growth spurt is, say you were going to grow 6 inches, okay, you may only get 1 or 2 inches of growth on one side and 6 inches on the other side. And all of a sudden you have a 4-inch leg length discrepancy. So if you have somebody that you see either in your clinic or in the emergency room, and they have not completed their growth spurt, in other words, they haven't finished growing, okay, and they have a fracture through, not the epiphyseal line, because that means the plate has fused, okay? That's the way it is in us, okay? Our plate, most of us, I assume all of us, we now have a epiphyseal line, we no longer have a epiphyseal plate. But if you have a patient that has a fracture through this epiphyseal plate, then that is an automatic consultation to the orthopedic surgeon. And it'll probably be scheduled for surgery so that they can approximate this back as best they can to try to make sure they minimize any growth discrepancies. Sales and organization. We have a stem cell here, okay, an osteogenic cell. We have an osteoblast, okay, which is going to be responsible for forming bone, okay. We have an osteoblast, which is going to be responsible for forming bone. We have an osteocyte, which is going to be responsible for maintaining the bone. Those are the cells that are living in the lacuna, okay. An osteocyte is living in the lacuna for maintaining bone. And then when we break down our bones, and we actually mobilize all the bones in our skeleton once every 10 years, obviously not all at the same time, but our skeleton is essentially replaced every 10 years. So I'm fixing to be 70 years old. So that means my skeleton will have been replaced 7 times since the time I was born. And so if you're 20 or 30 years old, your skeleton's already been placed 2 or 3 times. And so we have the stem cell here, okay, the precursor cell. osteogenic cell. We have an osteoblast, which is going to lay down bone. We have and so these are important important cells when we have a bone fracture, or when we're remodeling. These are osteocytes, which are going to maintain the bone as they are walled into their little chambers when they're as the osteoblasts are walled into the lacuna as they lay down the concentric lamellae, they become osteocytes for maintenance of the bone. And then when we have to do resorption of the bone, for whatever reason, is the osteoclasts that are responsible for bone resorption, okay? Lamella we talked about are those concentric layers laid down in opposite directions. The Haversian canal we talked about, they contain the vessels. There's a nerve, artery, and a vein there. The lacuna house the osteocytes. We talked about that. Those are the little chambers there that house the osteocytes. The Volkmann's canals, these are the vessels here. These are Volkmann's canals that allow the vessels continue that connect and nourish. These are the Volkmann's canals right here that you have connectings from one vessel to the other, and also Volkmann's canals that are providing vessels into the spongy bone. Remember, this is compact bone. We have spongy bone. Well, spongy bone needs a blood supply also. Canaliculi bring nutrients to the individual bone cells, which are the osteocytes. They're the ones that are lulled into the lacuna. It's like a Edgar Allan Poe story where this person was walling in somebody else and was laying brick by brick by brick, and then finally laid the last brick and realized that they had walled themselves in and the other person was actually going out the door. I don't remember the name of that story. Spongy bone has no osteons. So we have compact bone and we have spongy bone. And in a lot of places, we have both of them present. Here's the skull here. This is compact bone here. This is compact bone here, and this is spongy bone here. And this is how the spongy bone looks. Trabecular framework of bone tissue. We have a matrix, okay? That is the hard portion of the bone. One of the major portions of the matrix is hydroxyapatite, which is calcium phosphate. That's where the calcium and phosphate is stored. We have collagen, and as you can imagine, we have proteins and carbohydrate complexes, proteoglycans, and glycoproteins, okay? So if you got a question about that, you just come to this slide. But this is the big one, the hydroxyapatite, because that's how we store calcium in the bones, is hydroxyapatite. Bone development, we have two ways that bones develop, okay? They either develop along a membrane. This is usually the flat bones, okay? They have ossification centers, and so they develop along a membrane, and then the ossification centers join up. So if you had a little town here and a little town there and a little town there and a little town there, and eventually all the little towns got, bigger and bigger and bigger, and then all of a sudden they joined and now they're one big city, okay? That is sort of intermembranous bone development. Builds from the inside outwards, okay? And we'll go over that particular development here. So what we have here is these mesenchymal cells. These mesenchymal cells differentiated into osteoblasts, okay? These mesenchymal cells differentiated into osteoblasts, and these osteoblasts started laying down osteoid. Osteoid is the matrix material that's going to become hardened over time and form the hard part of the bone. So these mesenchymal cells differentiated, this is membranous bone formation, differentiated into osteoblasts. They start laying down osteoid, okay? In the process, this is called an ossification center, okay? As these ossification centers go on, we're laying down more and more of this osteoid, okay? We're laying down more and more of osteoid, and you can see that some of these cells from this ossification center are now becoming walled in, okay? They're now becoming walled in. So all these osteoblasts continue to secrete osteoid, which is calcified within a few days. The trapped osteoblasts become osteocytes, okay? So these are osteoblasts that are continuing to secrete osteoid. We had a bunch of them here together, okay? We had some on the periphery and some here together. And remember, there's not just one ossification center like I tried to give you the example of a bunch of little towns growing and then all of a sudden they became one big town. The same thing here. We have multiple ossification centers going on along this membrane, okay? So in this particular thing, now we have these osteoblasts that are walled off in this osteoid, and now they're going to become osteocytes. And then we're going to have woven bone form and we're going to have periosteum form. The accumulating osteoid is laid down between the embryonic blood vessels. So we have to have blood vessels coming in here. We got to have blood vessels coming in here to the spongy bone. Okay, we're going to have blood vessels coming in here to the spongy bone, but we also had to have some woven bone laid down. Okay, we're going to have some woven bone laid down, and that is the osteoid as it becomes harder. Okay, we're going to have again some of these mesenchymal cells condensing. What I'm doing, and I'm using the reading view as opposed to the slide view, because the slide view keeps bringing these things in one at a time, and I'm trying to just have it all together so I can explain it. These mesenchymal cells also differentiate and become periosteum. Remember, we have endosteum, which is the lining inside of the canals and inside of the woven bone, or inside of the compact bone, and also over the top of all these trabecula. So accumulating osteoid is laid down between the embryonic blood vessels in a random manner. The result is a network, instead of lamella, of trabecula called woven bone. So this is the woven bone here. This is a net, because the osteoid is laid down in a random fashion, because it is laid down around these blood vessels that go all directions, okay? Then we're going to have trabecula formed rather than lamella formed. And so then we're going to have these mesenchymal cells are going to differentiate into periosteum over the outer part of the woven bone here outside the trabecula. Then finally, lamellar bone replaces the woven bone just deep to the periosteum. So we have lamellar bone, okay? So we had periosteum put over these trabecula. Periosteum put over these trabecula with some woven bone here. Periosteum put over the trabecula with some woven bone here. We had the woven bone that was beneath the periosteum, outside of these cavitations, then becomes lamellar-like. In other words, becomes compact bone. And now we have essentially our skull. We have periosteum, okay? We have, if this was the outside of the skull, we have periosteum, we have compact bone, we have spongy bone, and then more compact bone here. And then this would be a inner coating. This would be one of the layers of the dura or the inner layers of that go on top of the brain that we'll talk about in a little bit. Okay, that is membranous. That is membranous growth. Okay, that is membranous growth, usually of the flat bones. Membranous growth of the flat bones. So you have a membrane there. This is growth based on a cartilage pattern. We have all our bones. Most of our bones are hyaline cartilage. Okay. We are going to use that hyaline cartilage as a blueprint. Going to use the hyaline cartilage as a blueprint to develop bones. Okay. The first thing we're going to do is lay down a bony collar along the longest portion of the bone. In other words, the pre-diathesis. We're going to lay down a bony collar here, and that's going to give us some stability. That's going to give us some stability, because you can imagine we're going to form an ossification center here in the long canal, and that long canal is going to cavitate out. So if we didn't form some type of support here, this thing would have a potential for collapse there. Okay. In the flat bones, we're not worried so much because we're gonna have woven bones laid down at the same time, and we're going to change that to a lamellar bone. But in a longer bone, we're looking for some support. So the first part of bone development, interchondral bone development, which is bone using a cartilaginous framework, hyaline cartilage, is to lay down a bone collar along the prediathesis. And our first primary ossification center is going to be in the shaft of this prediathesis. So the bone collar forms, then our primary ossification forms right here in the middle of the hyaline cartilage shaft. Okay, so here's our ossification center forming in the middle of this shaft. Okay, cartilage in the center calcifies and cavitates. What happens is the chondrocytes, okay, because this is still this is cartilage, the chondrocytes grow and grow and grow, and eventually they're replaced. They're eventually replaced. So we're going to have cartilage in the center calcifies and cavitates. Perichondrium becomes infiltrated. The outside of the bones called periosteum, outside of the cartilage is called perichondrium. So outside of the bones called periosteum, outside of the cartilage is called perichondrium. The perichondrium is going to become infiltrated with blood vessels, and these blood vessels are going to grow into these primary ossification center. And we're going to essentially have the same type of thing that happened before. We're going to have a cavitation here, except it's not going to be replaced. It's not going to be replaced by spongy bone. It's just going to be left. Okay, where it's not going to be replaced by spongy bone. Secondarily, we have as a second step, we have ossification centers in both of the epiphysis. Remember, we have a proximal epiphysis and a distal epiphysis. Okay, there are eventually going to go through a similar step that we talked about in membranes formation, where we're going to have outer compact bone and inner spongy bone, outer compact bone and inner spongy bone on the proximal and distal epiphysis. And so these are the stages of this bony development. Obviously, if you get a question, this could potentially be one of the essay they're called essay questions. I call them short answer because they don't have a drop-down menu for short answer questions. You always have to pick essay if you're going to write something. And so this could potentially be a compare and contrast membranous bone formation versus interchondral bone formation. So you could look at these and write a few sentences. Obviously, you don't need to draw anything, but you could look at these and write a few sentences and get the gist of what you're trying to convey. Okay, get the gist of what you're trying to convey. Bone growth and remodeling. Okay, we can add length. Okay, we can add length to the bone. That's called interstitial, or we can add surface area. That is called appositional. People who are heavier in their frame, okay, people who are heavier in their frame obviously need thicker bones. So if you've got a 200, 300 pound lineman that's, a huge amount of muscle, okay, obviously their femur is probably thicker than my femur is, okay, because I don't weigh that much, nor did I ever have that much muscle, okay? That would be appositional growth. That would be adding to the surface, and that would be related to stress factors, okay? You're putting, if you weigh 290 pounds, you're putting additional stress on those bones, okay? Whereas interstitial growth is adding length, okay? We're going to talk about that in just a minute as it relates to the growth plates. Growth of long bones depends on the presence of the epiphyseal cartilage, okay? The epiphyseal cartilage, the epiphyseal plate. So the epiphyseal part, this is the epiphyseal plate or the epiphyseal cartilage. Notice after this fuses, it becomes an epiphyseal line. So in you and I, we have epiphyseal lines. But in in younger individuals, until they have gone through their growth spurt, they still have epiphyseal plates. And so, as I told you previously, that's a very important consideration if you have a fracture in this area, because you get a leg length discrepancy. Okay, that's a serious thing. That's a serious thing. There's a number of ways to treat it, of which I don't have a clue what it is in this day and age. In the old days, they used to put external fixators on with pins, both proximal and distal, go in there and cut the femur. And then your job as the resident on the orthopedic surgery service is go there and turn that little knob 1 millimeter every day. And so that they were going to try to simulate a break and form callus in there. Okay. And so the people, that's what they did. They laid there, and you went and turned the thing 1 millimeter of the day. And that, like I say, that's 30, 40 years ago. I don't have a clue what they do now. Okay. So we need, in order to increase length in the long bones, which is where we get our additional height, increase length in the long bones, okay, we need to have the epiphyseal and active epiphyseal cartilage, okay? This is, now we're looking at the epiphyseal plate. We're actually looking at the epiphyseal plate. Here's the epiphyseal plate. We have taken a cross section through the epiphyseal plate. This is the resting zone. In other words, this is the area above the epiphyseal plate. Nothing new is going on there, okay? This is the proliferation zone. So we're talking about going from superior downwards. We're talking about going from superior downwards. This is the proliferation zone. These cells are going to divide. As these cells divide, they push the epiphysis away from the diaphysis. We're going to form, this is where we're going to form our additional length here. Okay, this is where we're going to form our additional length. So this is the resting zone. This is the epiphysis up here. This is the area that's not actively dividing. This is the epiphyseal plate. So the epiphyseal plate starts right here at the bottom of the resting zone. First area here is the proliferation zone. This is where the cartilaginous cells undergo mitosis. After they undergo mitosis, we have some hypertrophy going on. God, I'll have to go back the other way next time. We have some hypertrophy going on, okay? So the older cartilage cells enlarge, okay? Now remember, this is the epiphyseal plate. This is the epiphyseal plate. So this is cartilage here. So the older cartilage cells enlarge. They then become calcified. And then they become ossified. So if you get that in your mind, this is a section through the epiphyseal plate. The resting zone is the epiphysis up here. The growth is going to be on the diaphyseal side, the diaphysis side of the epiphysis. In other words, down in this direction. We're going to have our proliferation zone here, our hypertrophic zone, where our proliferation zone of our cartilage cells. They're going to hypertrophy and cavitate. They are then going to become calcified. Okay, they're going to then become calcified, and then as they become calcified, matrix is going to calcify, and then new bone is formed. So that is how bone growth occurs. And so that could easily be another question that could be asked on the exam, is explain how these 4 cell layers and how bone growth occurs. And you want to make sure that the growth in the epiphyseal plate occurs on the diaphyseal side. And those are things. So we have the hypertrophy. We had the proliferation zone, okay, facing the epiphysis, divide and push it away from the diaphysis, just like we talked about. So the epiphysis is pushed away from the diaphysis. The hypertrophic zone, older chondrocytes, hypertrophy. We have a calcification, the matrix calcifies, and then we have ossification. The cartilage spicules may become ossified. So this is what happens when we are during our bone growth time. Remodeling results where osteoclasts secrete digestive enzymes that break down the bone and then remodel the bone as it's needed, okay? Requirements for ossification. In other words, what do you and I and everybody in the world need for ossification? Number one, we need vitamin D, okay? Vitamin D is required for absorption of calcium. Hydroxyapatite is one of the major constituents of the osteoid being laid down and the calcification. We have hormones, okay? Growth hormone comes from the anterior pituitary. How are you going to remember that 4 years from now when you're taking your exam, okay? And you didn't realize that they were going to ask you this question, even though it said part of the exam's physiology. I am telling the way I remember this, and I'll repeat this several times when we get to endocrinology chapter 16. They are two hormones produced by the posterior pituitary. They are antidiuretic hormone and oxytocin. Antidiuretic hormone, ADH, and oxytocin. Antidiuretic hormone works in the kidney. Oxytocin primarily works to cause the uterus contracts during delivery of the infant, okay, during delivery. And it works a little bit on the breast too, okay, to cause the breast ducts to secrete milk. If they ask you if a hormone comes from the pituitary is made of two parts, anterior and posterior part. Posterior only has two hormones. All the other hormones from the pituitary come from the anterior pituitary. So that's how I remember that. So write that away, remember that, and that'll hold you in good stead sometime later on when you get that question out of the blue that you didn't know. And it doesn't have to be about growth hormone, it could be something else. Growth hormone from the anterior pituitary controls the epiphyseal plates. Thyroid hormone from the thyroid monitors the growth hormone to provide proper proportions. Sex hormones create growth plate spurt and then cause the epiphyseal plates to close. So we have an interaction between these three hormones. Growth hormone from the anterior pituitary, thyroid hormone from the thyroid, and sex hormones, okay, all work in an interaction during the growth spurt. We have to have calcium. If calcium's low, because the production of the parathyroid, calcium is mobilized from the bones. Okay, if we mobilize too much calcium from the bones, then we get osteoporosis of the bones. If we have a high calcium level, then we're going to have hydroxyapatite crystal formation. Okay, along with phosphate. So this is going to be stored in the bones. Stress of a prolonged load encourages the laying down of bone for protection and stability. That's what I talked about on somebody who, for whatever reason, either excessive weight, a large frame, whatever activities they do puts particular stress on those bones. That would, in order to maintain those bones against those stress factors, their additional bone may be laid down. Fractures and repairs. I've been teaching this for 5 years. In the old days, until last year, if you took Anatomy and Physiology 1, at the end of Anatomy and Physiology 1, you had a comprehensive final exam. And it was made by the faculty on each campus, okay? Made by the faculty on each campus. And I had nothing to do with it other than I picked it up on the day of the exam, administered it to you, and then took it back to the assessment center, and they graded it the next day, and I gave you the scores, okay? And one of the, while the students were taking it, I looked at the test, and they had a fracture on there that I hadn't taught, okay? And so I always remember that. That was the first Anatomy and Physiology 1 class I taught. The first class I taught was Anatomy and Physiology 2. Fracture and repair. We have hematoma formation. What happens, obviously, when you break a bone, there's a lot of blood vessels that are torn. Okay, blood vessels are torn and bleeding occurs into the area. The bone cells die, the localized bone cells die because there's no nutrition, because of the hematoma formation. Blood cells are broken, hematoma formation, clot formation, no blood supply, bone cells are going to die. In a femur fracture, a person with a displaced femur fracture can lose up to 2 to 4 units of blood in their thigh. Can lose up to 2 to 4 units of blood. So if you have somebody who has bilateral femur fractures, hypotensive, it may be, and has no other injury whatsoever, no other injuries, you know, a big metal thing dropped on their legs or something like that happened to them. They got bilateral femur fractures. They become hypotensive. It may be from blood loss, and you might not see the blood loss, especially in somebody with big thighs, And that's their only injury. So always remember that there's a huge potential for blood loss in femur. There's potential for blood loss in any bone fractures, but we were always, when I did the 5 years of trauma over at UF and Shands, that we always kept that in the back of our mind. So the first thing we get is hematoma formation. We got dead bone cells. Okay. Then we're going to get a callus formed, and the callus is going to be laid down with fibrocartilage. Okay. So what first is going to happen is the phagocytic cells, in other words, the neutrophils and secondarily the macrophages, are going to come in and clean stuff up. Okay. They're going to come in and clean stuff up. And then we're going to get a fibrocartilage formation here, okay? So this is going to act as remember we used hyaline cartilage for our endochondral bone formation. This is going to act as our framework, okay? So fibroblasts and osteoclasts, okay? Again, restructuring process to bridge the gap, okay? Osteoclasts are going to, we have osteoblasts that lay down bone, we have osteoclasts that restructure bone, resorb bone and restructure, okay? So all these cells in concert are going to lay down this fibrocartilage framework, okay? Then we're going to replace the fibrocartilage framework with a bony callus, okay? Neurotrabecular form and convert fibrocartilage callus to a bony callus. So we started with a hematoma, we cleaned up that area, okay? We did some remodeling, we laid down a fibrocartilage framework, okay? Then the fibrocartilage framework's going to be replaced, and we're going to have a bony callus formed, okay? With trabecula here, So we're going to have a bony callus, and then we're going to have a bony remodeling, okay? We're going to have bony remodeling because we essentially had we had this particular thing, bony callus of spongy bone. Well, that's not going, in a femur fracture, we don't want spongy bone going across the fracture line. We've got to have compact bone on both sides and spongy bone in the middle. So we've got to have some bone remodeling. So we have our compact bone formed here, and then we have our spongy bone reestablished down the middle. And those are the 4 steps in fracture and repair. Okay, and these are, I'm a big fan, I think I've told you, of utilizing pictures, okay? Once you understand the words, you can go back and look at the pictures, and you can get a good review about the pictures. And so I love looking at pictures, because when I go back and review the stuff, because for every lecture I go back and I read it last night. I read my instructor's notes last night. And then this morning I went through the slides, because even though I go through this once or twice a semester, I always like to, because there's always parts that throw me up, and I always like to get them, make sure I understand those. If you have problems healing the fracture, you can use electricity. There are some molecular factors you can use now, okay, on the molecular level, that can help remodel. And there are some people that have a very difficult time, especially with a second and third break in the same general area, of healing the bone. This is the thing that I use, where you replace the entire skeleton over a course of 10 years, okay? So if you're 20 years old, then your entire skeleton's been replaced twice now, okay? These are different types of breaks, okay? You want to know those, because if you are the PA, the nurse practitioner, or you're the nurse in the ER, or you're the orthopedic surgeon, or the ER physician, you want to be able to communicate the information to the person that you're calling for a consultation. My brother is an orthopedic surgeon. He does primarily trauma. He works for a huge group in Memphis, and him and some partners take care of their trauma, and they take care of the elective stuff. So these are the things, when somebody calls him from the emergency room, he'd like to know, because he needs to know this as to whether or not he's got to get up, if it's at night, and come on into the ER, or whether he can say, put him in a splint or put him in a cast, and I'll see him in the office in the morning. First one is non-displaced. You have a fracture, either incomplete, which means it'd be through one cortex. Say it's a long bone, you got two cortices, a long bone, spongy bone. You can have a complete break all the way through there, but the ends are essentially still in the same place they were if you didn't have a break. Okay, that's non-displaced. Ends are in normal position. Displaced, the ends are out of alignment. So if you had a displacement and then had movement afterwards of those ends, they would not be in what we call anatomical alignment, so they'd be displaced. So the first thing you'd want to say is, I have a fracture of the humerus that is displaced, okay, or non-displaced. It is complete, in other words, broken through, if we're talking about the humerus, broken through both cortices, okay? Or it might only be for, unlikely, but it could happen if it's in a younger person, the bones still haven't completely ossified, could have one cortices broke, okay? But it's usually complete, but it could be incomplete or complete, okay? So a non-displaced incomplete fracture is probably going to only require a splint or a cast and be sent to the orthopedic surgeon to be seen the next day or the day after, okay? Whereas a displaced fracture with a complete break, if it can't be reduced in the emergency room by the ER physician, the orthopedic surgeon may or may not need to come in. Depends on what bone it is. Open, that means the bone has broke through the skin and is sticking out. Closed means the bone has not broken through the skin. In the old days, if you had an open fracture, that needed to be fixed. And usually what happens, if it was a long bone, if it was a humerus or a radius or something like that, you would have pins put in proximal and distal and an external fixator put in. As opposed, since it's an open fracture, it's contaminated, okay? It's contaminated, so you wouldn't want to put a plate on it right away because a plate's foreign material, so you'd have an external fixator put on it and have it put in alignment, okay? Nowadays, my brother says that if it's a open fracture, but it's not a dirty fracture, in other words, you weren't working in the plant, okay? You weren't working in the plant and got a fracture through both bones of your forearm and they're sticking up to a whole bunch of dirt. If it's a open fracture, but it's not dirty, then he can see him the next day. But that's a relatively new thing. When I was going through training like say 30, going almost 40 years ago, if you had an open fracture, that got fixed that night or the next morning. That was a surgical emergency. And so open fracture is break through the skin. A closed fracture, just the bone's damaged. Okay, we can have a comminuted fracture. Okay, comminuted fracture means it's fractured in multiple areas, or we can have a compressed fracture. This is the total height of the vertebra. This is a vertebra that's been compressed and fractured. Okay, total height of the vertebra, this vertebra that's been compressed and fractured. So this is a comminuted fracture. This is a compressed fracture. These are all just terms. We can have a spiral fracture. The spiral fracture goes down in this direction, or we can have a epiphyseal fracture along the growth plate. Remember, if you are taking care of these people initially, and you are either working in a clinic or you're working in the ER and you get somebody who hasn't completed their growth spurt and you look in the fracture, it involves the epiphyseal plate, let me assure you, you need to call the orthopedic surgeon, okay? Because it would almost be and I can't think of the word, it's dereliction of duty, okay? It's not the standard of care because that would be, it would be required have a consultation. Now, if the orthopedic surgeon says send them to the office the next morning, then that's what you do and you document that's what the orthopedic surgeon said, okay? But you need to call and you may actually need to call a pediatric orthopedic surgeon, because these are people that deal primarily with these things in the pediatric population, but that you would need to get a consultation from somebody, or at least call somebody who has an area of expertise. You could very well be that person. You could be an orthopedic tech, orthopedic PA, orthopedic nurse practitioner, or you could be an orthopedic surgeon, okay? So you could very well be that person, but just remember that this is an important injury, okay? You can have a depressed fracture. Remember, we have an outer and an inner table of the cranial bones. You can have a depressed fracture where the fracture goes through both tables and the bones actually depress into the cranial cavity. Okay, obviously, that is a something that requires a urgent trip to the operating room. Okay, or you can have a green stick fracture. This is primarily in young people where only one cortices of a bone is broken, and not both cortices of that bone, only one cortices of the bone, and that's a green stick fracture. Those are our fractures. Okay, those are the names of the fractures. Like I say, since your test is open book, open notes is not as critical that you memorize them, but it is critical that you know where they're at because the test is time sensitive. Osteoporosis is a big problem. Normally, we have a good bony, spongy, bony network. Okay, and with osteoporosis, a lot of that stuff gets mobilized. Okay, there's some reasons for it. The spine is mostly affected. Okay, it's accelerated with cessation of the sex hormones, especially in females after they go through menopause and they no longer have that estrogen stimulation. They no longer have estrogen stimulation. And with males, as their testosterone level goes down, and males' testosterone level starts going down in the 30s. As that happens, okay, then estrogen and testosterone discourage osteoclasts. Osteoclasts are the mobilization things. They discourage that. Well, as that goes down, okay, as your estrogen goes down, your testosterone goes down, that discouragement goes away, and so the osteoclasts become more active, okay? You also can get it from insufficient exercise because exercise will put tension and strain on your bones, okay? You can get it from poor diet. You can get it from low vitamin D. You can get it from smoking. That reduces estrogen levels. You can get it from hormonal relating causes. It tends to hit the vertebra and the head of the femur. A lot of older people break their hip. Okay, my dad broke first one hip, had the hip surgery done, rehabbed, went back to his house, broke a second hip, ended up going to after assisted care and never got out of assisted care. It's usually once they break a hip, okay, once they break a hip, it's usually on the downhill journey. It's usually on the down, and we'll have a slide that says that. But there's a lot of causes here. My mom had a hysterectomy and bilateral oophorectomy, so they took her two ovaries and her uterus, and they didn't put her on hormone replacement therapy. And she got bad osteoporosis, and she swore she sneezed and broke some vertebra and broke some vertebra and broke some ribs. And it could very well have been, okay? But she had bad osteoporosis. If you go to a screening thing now, especially if the screening involves older people, one of the tests they get is an osteoporosis test because it is so important. You can get hormone replacement therapy, okay, which will stop the damage. It doesn't reverse the damage. You can take Fosamax, okay, suppresses the osteoclast, can reverse the damage. You can get, in the old days, you got estrogen therapy. The problem with estrogen therapy is increased risk of uterine cancer and increased risk of breast cancer. So you had to balance the osteoporosis with the increased risk of cancer. Now they're targeting the receptors, okay? Just like during your career, they will do a genetic modeling of whatever cancer your patient has, and the therapy will be directed against that genetic profile. The therapy will be directed against that genetic profile. And so they are getting more and more specific about being able to give medication, okay, that stimulates these estrogen receptors, okay, or provides for estrogen and provides for an estrogen-like substance without the bad sequelae. A little side note, if you haven't seen Contagion came out in 2011 with Matt Damon on it. You really ought to watch it, okay? We watched it last night. We saw it when it came out. We watched it last night. They had a virus come out of Hong Kong, not in China, but come out of Hong Kong and swept the world. And they talked about social distancing. They talked about wearing masks. They didn't have a treatment. They didn't have a vaccine. And so if you haven't seen that movie, you ought to see that movie because it was literally parallels the things that are going on now. Okay. Peak calcium intake is in the 30s. After that, it's too late. However, you can maintain supplements and exercise that gives you some beneficial things. So I always think fracture in older people, or I always think if you have an older client that comes in, doesn't matter if you're a physical therapist, you're an occupational therapist, if they, always think about osteoporosis. You can always recommend they take supplements, or you can always recommend they go see their doctor. 75% of elderly patients afflicted with osteoporosis, they fall and break a hip and are dead within 2 years following the incident. Most of the time, it was the thing that killed them, because in an older patient, most of the time, they weren't healthy enough to undergo surgery. So you put them in bed and you put them in traction. And when you did that, by putting in traction and putting in bed, they got atelectasis, which is collapse of some of the alveoli. Well, if you have collapse of the alveoli, you have a perfect warm environment, and you have bacteria all around you, both inside and outside your body, and they're in a hospital, which, contrary to popular belief, it's not the cleanest place in the world. Okay, it's one of the dirtiest places in the world. It's where all the disease is, and so you have bacteria there, and they would get pneumonia and die. And so that was the problem with hip fractures in older people 20, 30 years ago. Now they get them in. My brother gets them in. Depending on how many medical problems they have, they get an internal medicine consult, and whoever, cardiology consult, and they fix their hip fracture the next day. Okay, as soon as they are cleared by the medical specialist, they fix their hip fracture and they get them up walking the day after that. And so they no longer lay in bed for 3 months to heal that hip fracture, and they're now up walking. So if they get a hip fracture tonight, come in the morning, get cleared by the internist, and if it has a cardiology problem, by the cardiologist, and would have their surgery probably tomorrow afternoon or the next morning. Okay, to be able to get them up and get them mobilized, because that way you're avoiding pneumonia. Okay. Like I said, my dad had his first hip fracture. He was able to get rehabbed and go back to his house. When he had his second hip fracture, he never got back to his house. Rickets or soft tissue due to insufficient calcium or vitamin D. The epiphyseal plates don't calcify. They widen and lengthen, resulting in bowed bones. Okay. There again, this is something that we used to learn. Never saw rickets. Okay. Never saw rickets. You may see rickets in your practice if you go into the medical field. You actually may see rickets for the very reasons that I told you about. A lot of people coming to this country have not had adequate medical care, okay? Have not had adequate medical care. So you may see some of these diseases we just talked about. This is where we're going to stop here. There's just a few slides on the axial and appendicular skeleton. If you were here at the start of the lecture, what I said was traditionally you had, sometimes you were in 12-week class, we did this whole lecture during one session because there's only about 30 or 40 more slides. And then you have 1 or 2 labs on the axial and appendicular skeleton. So we're going to stop right here. We'll have the rest of the lecture. Next time, we're going to talk a little bit about the lab now. Because if you looked at it, I want to make sure everybody understands about the lab. This is our lab module here, okay, for this chapter, okay? And there should be 2 videos here. All righty. Oh, you know what? Probably what's happened here. Hold on, everybody. All right, I'm going to have to log back in our well, maybe I'm okay here. Canvas. Okay, here are the two videos, okay? This first one is primary, the axial skeleton. This is one of the professors at one of the colleges reviewing the bones, okay, reviewing the bones. This one, first one is 7 or 8 minutes. This is 4 to 6 minutes. Unfortunately, on the second one, either he or somebody in the background has a song going, and it's a little bit annoying, okay? Let's watch this just for a few seconds so I can sort of.
I'm going to do the axial skeleton for the first lab test. I'll start with the skull, and this is the frontal bone in back. Posterior, the occipital bone. Structures on the occipital bone are the foramen magnum, which is the large hole on each side, the occipital condyles. The external occipital protuberance is the bump on the back of the head. You can abbreviate this EOP. All right. Parietal bones. On the side, temporal bone will be right here. This is the flat part of the bone.
So this is what I want to tell you about this. Okay, you are when we would do the labs, traditional labs, we do the axial skeleton. I would give them a bone list. Okay, 3 or 4 pages of bones that they needed, the bones and the structures that they needed to do. Same way with the appendicular skeleton. When they took the test, I would give them a list, a word list, okay? But it would be in alphabetical order. It would be in alphabetical order. So if you didn't know what they were, and it'd be about 100, it would be about 100 bone parts, okay? 100 bone parts. One example would be foramen magnum, okay? What the big hole at the base of the skull, okay, is where the spinal cord goes into the skull, okay? And that is called foramen magnum. Foramen means hole, magnum means big. It's big hole, okay? That was the advantage of in the old days of us taking Latin. What you're going to do is make your own word list. So I would write down skull, and I would write down all the structures he talked about. Skull, you have to realize, is the most complicated, okay? Skull, you have to realize is the most complicated. I'm going to show you what I gave as a practice practical not too long ago, and I'm going to show you the types of things I asked then, okay, which will be similar to the types of things I'll ask you next week. But you're going to make your own word list. So if you were taking this as a face-to-face student, I would give you a page with 100 words in alphabetical order, okay, of the axial appendicular skeleton. You would come up to a bone. There'd be a sticker on it that'd say number 3. And you'd look down, if you didn't know what it was, you'd have to look down your word list. Well, if you didn't have a clue, you'd look down 100 words every time you went to a bone, okay? So this is a twofold thing. Number 1, you are going to learn the parts of the skull as he talks through them. So you're going to, however you want to do it, you write it on a piece of paper, you type it up, however you want to do it. Then when you get to the skull, okay, and I have a photomicrograph of a picture of the skull, and those pictures are going to come right from your textbook, okay? They're going to come right from the textbook. They'll either be diagrams or actual pictures. They'll come right from your textbook. And I'll show you in just a minute. You will look at your word list, okay? And so if you see a picture of a humerus, when he does the humerus, which will be in the second video, he does the axial skeleton first. That is the skull, the vertebra, and the rib cage, except I think he forgot the vertebra, or he does the vertebra in the second thing, okay? Then you do the appendicular skeleton. Well, if you got the clavicle only has 2 terms in it. It's the acromial end and the sternal end. So you'd have the bone clavicle, you'd have sternal end, acromial end, and it's easy to figure out which one's which once he points them out to you. So you'll have the advantage of not 100-word piece of paper in alphabetical order, but you'll have a bone list. You will make your own bone list from watching his video, because he'll point out all the structures. Everything that I ask on the quiz will be from his structures. You'll have 50 questions on the quiz. 50 questions on the quiz. They'll all be off of your list that you make up. Yeah, it's going to take a little bit of work, but this is the way you're going to learn the bones. This is chapter 7. We did this in the lab. Okay, this is the way you're going to learn the bones and the structures of the bones. We're going to do something very similar for the muscles. Okay. With the tissues, I did it the way I did it because tissues are, to me, are hard. Okay. But this is a simple thing to do. You'll have a bone list. You'll know exactly which bone attaches to it. You'll see a humerus. You'll see a radius. You'll see an ulna, and you'll look on your bone list. You'll look under ulna. There'll be about 4 structures or 3 structures. All you have to do is figure out which one it is. You write it down. And you go on. So it's not going to be hard. These are 2 videos. This one is 7 minutes and something, and this one is 6 minutes and something. Like I said, he has that music there, just drives me batty. Okay, just drives me batty. These are the instructions. So this week, your job is to go through these 2 videos and make you a bone list. If you don't want to make a bone list, that's fine. That's up to you. But I would suggest making a bone list. And where he says you can abbreviate, you cannot abbreviate. Okay, where he says you can abbreviate, you cannot abbreviate. And spelling is going to count because you're writing the word down either on your computer or on your piece of paper. Okay, there's going to be 50 questions. There's going to be 50 questions, and everybody can make 50 points out of this. Now, let me show you what I gave as a practical not too long ago. Not as a practical, but as a practice practical. And this is not available to you. This is not published. So do not send me an email and say, Dr. Phillips, I looked for the practice practical and I couldn't find it. Well, you can't find it because it's not published. It's not going to be published. I'm going to use these same slides, but I'm not going to use these same numbered things. I'll change the numbers, okay? But this is what I use for a practice practical. So I just want you to get used to looking at these things because they are right out of your textbook. Okay, whatever that means. So if you didn't show up, you were not going to get this information because this won't be part of the lecture. Okay, so I gave this as practice practical 3 or 4 a couple of years ago. This would be a picture of something. Okay, this would be a picture of something. So if there was a number here, okay, this is the mental foramen. There's actually a nerve comes out here. This is the infraorbital foramen, okay? This is the frontal bone. So he goes over all of these, okay? He goes over all of these. So if you have these listed, and this picture came right out of the textbook, Here's another picture. He talked about, well, he didn't talk about the last part. He goes over the skull. He talks about the sutures. This is a sagittal suture, and this is the lambdoidal suture, okay? This is the lambdoidal suture. This is the occipital bone here. This is the parietal bone here, So these aren't hard. These aren't hard. In medical school, we actually got, in addition to having our actual dissections and skeletons and stuff like that, we actually had pictures. I did worse on the pictures and actually knew them, but I got confused and lost a few points on the pictures. This is what it's going to look like, and you'll just have numbers there, and it will be under the short answer. You'll have this picture here, and underneath it, if this was the picture, it'd have 3. It'd have name the structure, it'd have 3, and name the structure 4, okay? So this is just a picture of the skull. This is a picture of the skull here. This is the zygomatic arch. This is the temporal bone. This is the external auditory or acoustic meatus. He'll go through that, okay? I am not going to ask the tiny stuff. This is the mass. Number 6 right here is pointed at the mastoid process. This is the styloid process. These are all things you would need to know for your lab. But the difference between what you're going to do and what they're going to do, okay, is that you're going to have a word list attached to the bones. You're going to make up your own word list instead of a brand new 100 word list in alphabetical order, which would have mastoid under M and styloid under S. And if you didn't know either one of them, okay, you wouldn't know what to look for. That's the mental foramen there again. Okay, this is a picture of an actual skull. He's going over the actual skull, okay? This is the coronal suture, which is one of the things he would be going over. This is the external acoustic or auditory meatus. This is where the ear canal goes into when it goes into the bony portion of the ear canal. Okay. Notice this. I guarantee you 100%. Big hole, right? This is a big hole. It's called foramen magnum. These are the things that when we, used to, when you was going to go to medical school, nursing school, whatever school you was going to go to, you took 2 years of Latin, and that because all the things were Latin terms. Okay. But these are examples of the pictures you would have. And so if you miss that, I mean, I can't help you. Okay, that's the foramen magnum. He actually pointed that. I'm not going to ask little nitpicky stuff here, these little holes here. Okay, I'm not going to ask these little holes. I may ask some of the big holes. This is a bigger hole here. This is the foramen magnum. I may ask where the carotids come through, where the jugulars come through, and the foramen magnum. But I'm not going to ask these little tiny holes. Number one, they're hard to see. Okay, and I'm only going to ask 50 questions from the whole thing. Here's the foramen magnum from the other side. This is the sella turcica here. This is the sella turcica here. Okay, this is where the pituitary sits. And so you have in your textbook, you have multiple pictures of this. He'll actually put his finger in the sella turcica, and you can see, but it's called sella turcica means saddle. Okay, that's the foramen ovale. It is in an oval shape. Okay, it's an oval shape. This is a picture of the mandible. This is the mandibular condyle. This is the mental foramen again, okay? This is a foramen, okay? If you've ever had nerve blocks by your dentist, okay, he may have actually gone in here and injected right here because the nerve that supplies these lower teeth here, okay, comes right down through there, okay? And if you're doing a localized repair of the lip, okay, you can go in and put a little, you can actually palpate this sometimes, but you know the general area where it is, so you can put some local in there and say you got a minor laceration of the lip in this area, you can actually numb it right there rather than numbing the lip. If you ever have to repair the lip, make sure you take some kind of permanent dye, methylene blue or something, and you tattoo the two edges of the vermilion border, okay? Vermilion border is the junction of the red and the cutaneous portion, okay? Because once you put local in there, they're gone, okay? And nothing is worse than a zigzag repair on the lip where the red-white junction is zigzagged, okay? And if you don't do it before you put the local in, you'll never see it. This is a picture of the mandible. This is a picture of a vertebra, okay? This is a transverse process. This is a posterior process. That's not hard. Posterior process, transverse process, okay? This is, I won't ask this, but this is the, this is cervical vertebra number 2. This is the odontoid process. It actually articulates with cervical vertebra number 1. Sometimes this can be broken and impinge on the spinal cord up here, okay? Since you've never seen this and never actually got to put your hands on it, I've never asked you that. But that's what that is, okay? This is the manubrium, the sternum, and the xiphoid process. I love the xiphoid process. It starts with an X, okay? This is the clavicle, sternal end and acromial end. So when he goes over the clavicle, he will tell you this is the sternal end and the acromial end. That's all there is to the clavicle, okay? And you're going to see a picture of a clavicle. You probably won't get both of these, okay? But you'll just have to figure out one. And this articulates with the acromion of the scapula. This articulates with the sternum. It doesn't really make sense if you look on a model, because this is a flat, blunt end that's articulating with the sternum, which is flat, okay? And this thing is a round, flat, blunt end, okay? This is the scapula, okay? And so the scapula has a number of parts, none of which are hard. I'm not going to ask any hard parts, okay? But you should know what that protuberance is. You should know what that protuberance is. This is the spine of the scapula. This is the supraspinatus and infraspinatus fossas. This is the spine of the scapula. This is a fossa above the spine, which we call supra. And this is a fossa below the spine, which we call infra, okay? Back from Latin again, okay? This is just the scapula. So I was just, because this was a practical, and what I did was the week before we had the practical, I tell them to get out a piece of paper, and I just flip these up on the slide because this is a slideshow. But you're going to have these exact pictures because this is exactly what I'm going to use, okay? These are all out of your book. This is the humerus, okay? There's only about 1, 2, 3, 4, 5, and back on the other side, 6. There's only about 6 things on the humerus. You got to be able to recognize this as the humerus, okay? This is the other side of the humerus. That's the olecranon fossa. That fits the olecranon, which is the funny bone of the ulna. Okay, that's the protuberance of ulna, and it fits right in there, in this little depression right there, and that's the olecranon fossa. He will show you that stuff on the video, okay? This is the radius. This is the head of the radius. It's round, okay? This is how you can differentiate the radius from the ulna. This is the ulna here, and this is the radius. When you see this round head, okay, you know that's the radius, and you know that's the ulna. This is the olecranon. When you bang your elbow against the door and you feel that nerve thing shooting down, and you say, I hit my funny bone, this is what you're hitting, because your ulnar nerve goes right past this. Your ulnar nerve goes right past this on the medial side. You can actually palpate you can roll, if you go to the medial side of your olecranon, you can actually palpate your ulnar nerve, okay? So this is actually the olecranon there. This is the acetabulum, okay? This is this is the pelvis, okay? This is the acetabulum here. You can be sure with 100% certainty you're going to get that on the quiz, okay? This is where the head of the femur fits in the pelvis, okay? This is the anterior superior iliac spine. That's your hip bone. When you palpate your abdomen, that's what you feel right there, okay? Is the hip bone. That is the obturator foramen, okay? And he will point out all this stuff here. This is the sciatic notch. Why do they call it that? That's where the sciatic nerve goes through, down the posterior part of your thigh. These are your femurs, okay? This is your femur, okay? And it's just a picture, okay? This is your tibia, and this is your fibula. Fibula is always lateral to the tibia. The fibula is always lateral to the tibia. And so this is your fibula, and this is your tibia. So this would be from your right leg, as you can see up here. This probably on the exam, you won't have this picture here. But always remember that your fibula is lateral. The fibula is a great place if you have somebody who, say, it has a gunshot wound to the radius, okay, up in the forearm, the radius bone, and they're missing a piece of radius about 3 or 4 centimeters. You can take a piece of fibula with its vascular supply, with its regional vascular supply, and take it up there, fixate it with fixators, with plates or whatever you're going to fixate with, and then hook up the nerve, to hook up the artery in the vein, and replace that bone there. And you can use the fibula. This is the inside of your ankle. So when you palpate the inside of your ankle, that's the outside of your ankle. So these have names, okay? This is the foot. This is the hand. I am not going to ask the individual carpal bones. In fact, that's an extra credit question. We don't have extra credit in this class, but it's an extra credit question. I used to ask them with a word list. Okay, they had a word list. They had to name all 8 of the carpal bones. So if they knew them, they just went to their word list, 100 terms in alphabetical order, and they could pull them down. They got 5 points of extra credit. But I'm not going to ask you anything on the hand. And so that is what you will see for your quiz. How you're going to learn the quiz is you're going to watch those 2 videos, and you're going to, if you want to, make your word list. I would advise to make a word list, okay? That'd be my best advice, to make your word list so that you would have that information available to you. Otherwise, we will finish up the chapter next week. It's not going to be very many slides, so it will probably take about half hour, 45 minutes, and we may review some of the bony structures, okay? We may review some of the bony structures if you want to. Your quiz is going to be just like the other quiz is. It's going to be open for a week,